Hello to the audience. I would like to welcome everyone warmly on this Philips webinar. I would like to share my experience with the high-frequency linear probe. I would like to present clinical use of the high-frequency linear probe in the first and the second trimester of the pregnancy. I had the opportunity to work on Philips machine equipped with the linear probe EL184 during my 2 years training at Harris Birthright Research Center, whose director is Professor Kypros Nikolaidis, and now back in Poland at my local university hospital. Firstly, I would like to briefly describe Philips EL184 linear transducer. The first thing to notice is that Philips EL184 is a linear transducer, which is quite uncommon in obstetric ultrasound. Linear transducers are usually used for imaging of vascular or musculoskeletal systems and organs like thyroid, testicles, or breast. It is an ultra-broadband transducer, so it can generate frequencies ranging from 2 MHz to 22 MHz, enabling use in a wide range of clinical applications. It is a kind of compromise between transvaginal and abdominal transducers. It is also equipped with microflow imaging technique, which is a novel method for blood flow detections, and it can detect small blood vessels with high resolution and minimal artifacts. On the next picture, you can see some examples of use of the MFI technique. On the first video, you can use in the first trimester scan, you can assess the anatomy of the fetus, the intra-abdominal insertion of the umbilical cord, the free vessels cord of the baby, the renal arteries. In the next video, you can see the assessment of the vascularity of the kidneys at the third trimester of the pregnancy. On the next video, you can see the assessment of the brain vascularity. You can see nice pericostal artery using the MFI technique. And on the last video, you can see the assessment of the blood flows through the umbilical cords. It is quite useful as well to assess the placenta. Firstly, I would like to speak about first trimester scan, which is usually performed between 11 to 13 weeks. We are mostly concentrated about the screening for aneuploidies at this time of the pregnancy, but it is, in some countries, it is even considered as just a dating scan. The concentration on the fetal anatomy started around 30 years ago when Professor Szabo discovered nuchal oedema in fetuses with trisomy 21, and then Professor Nikolaidis 4 years later introduced screening for Down syndrome. For the last few years, the idea of an early anomaly scan is developing, and experts are pushing the first trimester scan to the limits. Assessment of the fetal anatomy at early gestation is now easier thanks to high-frequency transabdominal and transvaginal transducers. Very important aspect for the proper fetal scan is to follow the protocols. For the assessment of the fetal anatomy, systematic approach is essential to ensure that anomalies are equally likely to be detected for patients of any risk background. Therefore, we should follow the recommendations that are written by many organizations and institutions. There are a lot of papers, research and books regarding moving anomaly scan to the first trimester and pushing it to the limits. Research is mainly focused on the heart abnormalities, early neurosonography, and detection of open neural tube defects. There is also a lot of data what's the detection rate of the fetal abnormalities at first trimester scan, which varies from 50 to 60% and even to 80% if the scan is performed by an expert. There are a few aims of the first trimester scan. The first one is, of course, the assessment of the fetal viability. We need to perform fetal measurements at the first trimester. We need to assess the gestational age and the fetal anatomy. We need to see if there are any other intra or extrauterine structures that should be described in the report. The determination of the chorionicity and amnionicity in case of multiple pregnancy is obligatory at the stage of pregnancy. And of course, we can perform the screening for chromosomal abnormalities, but as well nowadays screenings for pregnancy complications like intrauterine growth restriction, preeclampsia, or vasoprevia. In this presentation, I would like to focus on the assessment of the fetal anatomy. When should be the first trimester scan performed? The best time is between 11 and 13 plus 6 weeks, or 11 plus 2 and 14 plus 1, depending on the chart's normograms we use, when crown rump length is between 45 and 84 millimeters. The optimal time for the assessment of the fetal anatomy is after 12 weeks, when the CRL is more than 60 millimeters. At this time, we can assess not only the anatomy, but also perform the screening for chromosomal abnormalities and screening for adverse pregnancy outcomes. There are two obligatory measurements that should be performed at this stage of the pregnancy. The first one is the CRL, crown rump length. We should obtain this measurement at the midline sagittal section of the whole fetus in neutral position. And another measurement is biparietal diameter, so it is measured on the largest true symmetrical axial view of the fetal head. On this video, you can see how easy we can perform the assessment of the fetal anatomy. With just few movements of the probe, we can see the fetal anatomy. So on the mid-sagittal view, we can see normal appearance of the head and the body of the fetus. Moving from one side to the other side, we can see the extremities of the fetus, the upper and the lower segments of the extremities. And in the transverse view, we can assess fully the anatomy, starting from the head, looking at the face, fetal abdomen, and of course, extremities as well. Starting from the top of the head, we assess the fetal skull and brain. So the major part of the head at this stage is filled with the echogenic choroid plexuses. With the use of high-frequency probes, we can assess not only the appearance of the skull and the choroid plexuses, but we can see more precisely the anatomy of the posterior fossa, like an aqueduct, thalami, and the appearance of the posterior fossa in axial views at early gestation. Looking at the fetal face should be assessed in the transverse view and the sagittal plane. At 11 to 13 weeks, an attempt should be made to visualize the eyes with the lenses, the profile including the nose, the nasal bone and the maxilla, and the integrity of the mouth and the lips. Going down to the fetal neck, this is a part of the screening for chromosomal abnormalities. So looking at the fetal neck, of course, we need to measure the nuchal translucency according to the FMF protocol. Attention should be paid to proper alignment of the neck with the trunk and identification of any other fluid collections, such as hygromas and jugular lymph sacs, should be noted on the scan report. Going down to the fetal spine, longitudinal and axial view should be obtained to show normal vertebral alignment and integrity and intact overlying skin. But most important, it is to look at the indirect signs of the spina bifida, because it should raise a suspicion of open neural tube defect. Therefore, when we have any concern and we see that biparietal diameter is below the 5th centile, or we can see the abnormal appearance of the aqueduct, which is called the crash sign, or abnormal intracranial translucency, we should pay attention to the assessment of the fetal anatomy. Next step of the assessment of the anatomy is the appearance of the fetal chest. We should see the shape of the chest, as the narrow chest can be a sign of the lethal skeletal dysplasias in the first trimester. Diaphragmatic continuity should be evaluated as well. And if there is any sign of the pleural effusion or masses, a follow-up scan should be performed in the next few weeks. Fetal heart assessment in the first trimester has developed to a great extent. Most protocols recommend just a basic assessment of the fetal heart. So we should just assess normal position of the heart on the left side of the chest to confirm levocardia. However, it is feasible to assess cardiac anatomy at first trimester scan. Therefore, we should provide basic screening for fetal heart defects with the use of color Doppler at first trimester, which should include visualization of stomach on the left side, then visualization of the filling of the ventricles, and main arteries called V-sign. This kind of easy heart assessment can lead to detection rate of major heart defects up to 80%. On the next video, you can see the full assessment of the fetal heart anatomy, starting from fetal stomach, then looking at the four chambers view and the ventricular outflows. You can see nice left and right ventricular outflow. With the use of the color Doppler, we can nicely see the main arteries, and with the use of the MFI technique, we can even see pulmonary veins at this stage of the pregnancy. On the next video, you can see the huge difference between the two transducers. So you can see on the left side the use of the C9-2 probe, and on the right side you can see the use of the EL18-4 probe, which is the linear probe. So you can see the difference in the fetal heart anatomy at this stage of the pregnancy, how precisely we can assess the fetal heart. Here are some pictures from the first trimester scan. So you can see that we can obtain all of the views that are recommended to see at the second trimester scan with this kind of transducers. So we can fully assess the fetal heart anatomy at this stage. And this is one case that I had scanned before. So this is a case of fetus with the trisomy 21. The crown rump length was 47 millimeters. So looking at the fetal face, you can see slightly increased nuchal translucency and absent nasal bone. There is a normal flow through the tricuspid valve and abnormal flow through the ductus venosus with reversed A wave. So apart from the markers of the trisomy 21, then looking at the fetal heart, we can see that there is a major heart defect, like atrioventricular septal defect. So you can confirm that with the use of the color Doppler, but even without the use of the color Doppler, we can see a huge atrioventricular defect. And with the use of the power Doppler, we can see there is additional marker, aberrant right subclavian artery. So on the next video, you can see that it is quite feasible to assess the appearance of the subclavian artery at this stage. This is another example of the normal fetus with aberrant right subclavian artery. This is another case of major heart abnormality. This is a case of tetralogy of Fallot with pulmonary atresia. So you can see the appearance of the ventricles, that the right ventricle is bigger. You can see abnormal overriding aorta with the use of the color Doppler. And looking at the great arteries, you can see that there is a pulmonary atresia. We cannot see the pulmonary artery at all. And another case with a left superior vena cava. As we know, this is quite uncommon to see such a small defects in the first trimester scan. But looking at the level of the three vessels, you can see additional vessel. And additionally, there is dilated coronary sinus when we are looking at the four chambers view. Going down to the abdominal content, we should be able to assess three basic structures: stomach, bladder, and the kidneys of the fetus. The stomach should be placed on the left side to confirm the levocardia, and it helps to confirm situs visceralis. With the use of the high-frequency transducer, we can also assess the position of the descending aorta, vena cava, and umbilical vein. Fetal kidneys should be noted paraspinally as a bean-shaped structures. In most of the cases, it's tricky to see well structure of the kidneys, therefore it is useful to assess renal arteries with power Doppler or MFI. The bladder should be visible in the lower abdomen, and the absence of the bladder should be followed up. Here is a case of abnormality of the kidneys at the 14 weeks. So you can see, looking at the kidneys in the coronal plane, that the right kidney is duplex, and there is a small cyst. So even in such early gestation, we can see this kind of abnormalities of the kidneys. The next step is the assessment of the umbilical cord. So the normal insertion of the umbilical cord should be documented after 12 weeks of pregnancy. The physiological umbilical hernia is present up to 11 weeks. So after 11 weeks, persistent varicella is considered as a marker for chromosomal abnormalities. The number of cord vessels and presence of cord cysts should be noted. Evaluation of the paravesical region with the color Doppler can be helpful in confirming the presence of 2 umbilical arteries. At the first trimester scan, we should as well assess the upper and the lower extremities, the presence of each bony segment of the upper and the lower limbs, and presence and normal orientation of the 2 hands and feet should be noted at 11 to 13 plus 6 weeks ultrasound scan. And you can see how easy we can see all the bony structures. We can as well count easily the fingers and assess the presence of normal orientation of the fetus. Assessment of the fetal gender should be based on the orientation of genital tubercle in the mid-sagittal view. However, it is not, of course, the part of the basic assessment at this time of pregnancy. We should explain to the parents that it is rather a prediction than the assessment of the fetal gender. Fetal sex determination is not recommended before 14 weeks due to the uncertainty of the test results. Apart from the fetal anatomy, there are some other intra- and extrauterine structures that we should assess during first trimester scan. The echostructure of the placenta should be evaluated. Abnormal findings such as masses, single or multiple cystic spaces, or large subchorionic fluid collections should be noted. Position of the placenta in relation to the cervix is of less importance at this stage of the pregnancy since most migrate away. The insertion of the umbilical cord to the placenta should be assessed as early screening for vasa previa. If we have a doubt about the cord insertion, if it is velamentous, a follow-up should be performed at 20 weeks. Special attention should be given to the patients with a prior cesarean section. In view of the increased rate of the cesarean sections nowadays, they may be predisposed to scar pregnancy or placenta accreta. If there is any gynecological pathology, of course it should be noted on the scan report. Now I would like to move to the second trimester anomaly scan and show some examples how a linear transducer can help us in the assessment of anatomy at this stage pregnancy. As in the first trimester scan, there are some aims of the second trimester scan between 18 and 22 weeks. The first one is to assess fetal growth and gestational age if the pregnancy was not redated at the first trimester scan. In most of the protocols according to the head circumference. We need to check for major structural anomalies. We should check for markers of chromosomal abnormalities like ventriculomegaly, absent nasal bone, or aberrant right subclavian artery, to check for placental position and ideally the cord insertion. If there is any doubt, it should be followed up. But as well, we can perform the screening for preterm labor with the measurement of the cervical length with the transvaginal probe, and to screen for preeclampsia with the use of Doppler by measurement of the uterine artery PI and maternal blood pressure. As in the first trimester, there are many recommendations written by societies or organizations focused on ultrasound imaging in obstetrics and gynecology. Assessment of the anatomy should be done following a systematic approach. Thanks to that, the detection rate of the fetal abnormalities will be higher. There are some measurements of the fetus that need to be performed at the second trimester scan. The first one is the biparietal diameter. We need to perform this measurement at the cross-sectional view of the fetal head at the level of the lateral ventricles. Ideal angle of insonation is 90 to the midline echoes. Symmetrical appearance of both hemispheres should be obtained, and continuous midline echo broken in the middle by the cavum sectum pellucidum without cerebellum visualized. And another measurement is the head circumference, which we do at the same plane. At that plane, we can as well, of course, measure the lateral ventricle. Another plane that we should obtain, looking at the fetal head, this is a transverse plane at the level of the CSP and the cerebellum. So at this level, we perform 3 measurements. The first one is the transverse cerebral trimeter, this TCB. Another is the cisterna magna, and the measurement of the nuchal fold. Going down to the fetal abdomen, we measure the abdominal circumference. So the transverse section of the fetal abdomen should be obtained with the visible umbilical vein at the level of the portal sinus. The stomach bubble should be visualized on the left side, and the kidneys should not be visible, and ideally we should see the adrenal glands. And the last 2 measurements that are obligatory at this stage of the pregnancy, we should measure 2 long bones, so the femur length and the humerus. The best anatomy to perform these measurements is we should obtain the view of both ends of the ossified metaphysis. The longest axis of the ossified diaphysis is measured, and the angle of insonation should be between 45 and 90. Now I would like to focus on the fetal anatomy. So this presentation is based on the ISPOC guidelines for performance of the routine mid-trimester fetal ultrasound scan. So we will follow these recommendations and add some additional planes to make the anomaly scan even more precise. So again, starting from the top of the head, we need to look at the fetal skull and brain. So when we are looking at the fetal skull, we should assess the size, the shape, the integrity, and the bone density. We need to get 3 planes to assess the fetal anatomy in the basic scan: the transventricular, transthalamic, and transcerebellar plane to assess the posterior fossa, and the following brain structure should be evaluated: the measurement of the lateral ventricles, the appearance of the cavum septum pellucidi, the midline falx, thalami, the measurement of the cerebellum, and the cisterna magna and the nuchal fold. Here on the videos, you can see the optional plane. That of course is not obligatory, but we can see nicely the corpus callosum with the pericallosal artery. And in the mid-sagittal plane, if we have any doubts, we can assess the posterior fossa, looking at the cerebellum and the cerebellar vermis. Here on the video, you can see the use of the linear probe in the 3rd trimester of the pregnancy. This is a 32 weeks fetus, which was in a bridge presentation. You can see how well we can see the anatomy of the fetal brain. With the vascularity in the mid-sagittal view, we can see nicely the appearance of the pericallosal artery and the anatomy of the corpus callosum. We can see all the parts of the corpus callosum. Next step of the fetal anatomy assessment is the fetal face. So looking at the fetal face, we should start from the mid-sagittal view, assessing the fetal profile with the assessment of the fetal nose, fetal mandible, and the maxilla. Then we need to as well see the face in the transverse views. So we should be able to assess the hard palate, the appearance of the eyes and the lenses inside. And we can as well see the nice coronal views of the fetal lips to check for any cleft lip. And this is the appearance of the fetus at the 36 weeks. You can see the breathing movements and normal appearance of the fetal face. You can see normal nasal bone, appearance of the lips and the chin. And with the use of the MFI technique, you can see nicely the breathing movements, how baby is breathing, and the movement of the amniotic fluid. On the next video, you can see the appearance of the fetal eyes. You can see easily the iris and the pupil. Then going down to the nose, you can see the nasal septum and the septal cartilage. And going a little bit down to the hard palate, you can see the intact alveolar ridge and the nostrils of the fetus. And this is another example of the assessment of the fetal eye. You can see the eyelashes, you can see the lens, iris, and the pupil, and how the fetus is moving the eye. Next step of the assessment of the fetal anatomy is the neck. So normally it appears as cylindrical structure with no masses or fluid collections. Obvious neck masses such as cystic hygromas or teratomas should be documented. And of course, the cervical appearance of the spine should be assessed. There might be a presence of hemivertebra at this level of the spine. This is an example of the use in the third trimester. We can really see well the spine and the spinal cord, the cervical part. We can see the brainstem and the spinal cord. But looking as well at the lumbar part of the spine, you can see nicely conus medullaris and cauda equina. Then we are looking at the fetal thorax. So the shape of the thorax should be irregular with a smooth transition to the abdomen. The ribs should have normal curvature with no deformities or fractures. Both lungs should appear homogeneous and without evidence of any mediastinal shift or masses. The diaphragmatic interface can be visualized as a hypoechoic line dividing between the thoracic and abdominal content. Next step is the assessment of the fetal heart, which is most complicated part of the scan. We need to assess a few planes to fully assess the fetal heart. On the videos you can see that we can see really nicely the anatomy of the fetal heart, all the outflows, nice 4 chambers view, 3 vessels, and the appearance of the aortic arch and the thymus. So there are a few planes that we need to obtain. That we need to see the chest shape, assess the ribs length, assess the heart size, location of the heart, assess the axis of the heart rate, 4 chambers view, the outflows, the 3 vessels view, and the 3 vessels trachea view. The optional views are the mid-sagittal views of the heart, so we can assess the ductal and the aortic arch. These views are of course optional. And this is the 36-week scan, so if we are lucky and the fetus is in a good position, we can see nicely the anatomy even at this stage. So you can see the 4 chambers view, the foramen ovale nicely, the 3 vessels view, and we can compare the thymus, that it is much bigger at this stage of the pregnancy. As in the previous pictures, you can see now the comparison of the assessment of the fetal thymus, as this is hypoplastic thymus is an ultrasound marker for deletion, 22q11 in fetal cardiac defects. So you can see the difference between C92 and linear transducer, and here at the level of 3 vessels and the aorta, you can see nicely the tissue of the thymus. Then going down to the abdomen and gastrointestinal tract, abdominal organ situs should be determined. The fetal stomach should be identified in its normal position on the left side. Bowel should be contained within the abdomen, and the umbilical cord should insert into an intact abdominal wall. Any cystic or any other structures seen in the abdomen should prompt referral for a more detailed scan and a follow-up. Here we can see a case of congenital diaphragmatic hernia. So you can see a 4 chambers view at the level of the chest, and a stomach inside the chest. You can see easily the appearance of the bowels inside the chest, and as well the lungs, which is quite important for the measurement and the follow-up and the counseling for any interventions. Then going down, we assess the bladder of the fetus. So the cord vessels may be counted using grayscale imaging or color Doppler as a routine anatomical survey. The fetal bladder should be identified, the size and the shape of the fetal bladder. If we have any doubts about the size or the shape, like a keyhole shaped bladder, a follow-up scan should be performed. Fetal gallbladder may be seen in the right upper quadrant next to the liver. However, this is not part of the basic anatomy assessment. Then looking at the kidneys, the structure and the size of the kidneys should be assessed. Both kidneys should be identified in axial or coronal view. If renal pelvis appears enlarged, a measurement should be documented. And here on the next video you can see the appearance of the hydronephrosis and the difference between the C9-2 and the linear probe, how well you can see the tissue of the kidney and the enlargement of the renal pelvis and the enlargement of the calyces. And this is another case of the kidneys abnormality. This is a baby with many abnormalities. There was also a spina bifida, but you can see that there is one kidney, a pelvic kidney. There were empty renal fossa, and the kidney was abnormally located. The next step of the fetal anatomical survey is the fetal spine. Transverse and sagittal views are usually informative. The most frequent of the severe spinal abnormalities, like open spina bifida, are usually associated with abnormal intracranial findings, like characteristic cerebellar deformity called banana sign or obliterated cisterna magna. On the next slides, I would like to show you some cases of the spina bifida. So in this picture, you can see the assessment of the level of the lesion, which is quite important when we want to counsel the patient regarding in utero surgery for the spina bifida. And here on the videos, you can see the appearance of the fetal skull. So you can see abnormal shape of the skull, which is called lemon-shaped skull. And there is a ventriculomegaly. There is abnormal appearance of the cerebellum. And looking at the lumbar part of the spine, you can see the lesion at the level L5 to S2. And in the coronal planes, you can see the lesion. And then looking at the transverse view, you can see as well the spina bifida. And this is another case, quite similar, but there was additionally kyphoscoliosis. So the same, you can see the abnormal appearance of the skull, ventriculomegaly, banana-shaped cerebellum, so Arnold-Chiari malformation. And then looking at the spine, you can see abnormal shape of the spine and the huge lesion in the sagittal and the coronal view. Next step of the assessment is the assessment of the fetal extremities. So as said before, we should perform some measurements of the long bones. So the measurement of the humerus and the femur should be taken. Of course, the presence of both arms, hands, and both legs, feet should be documented. We should as well count the bones in the forearms and in the lower legs. Counting fingers or toes is not required as part of the routine mid-trimester scan. However, with the use of high-frequency transducers, it is quite easy to do. And the last step of the assessment of the fetal anatomy is, of course, the genitalia. Before the assessment of this area, we should always ask parents if they want to know the sex of the fetus. Characterization of external genitalia to determine fetal gender is not considered mandatory in the context of a mid-trimester routine scan. However, we know that this is a frequent question from the parents that they want to know the fetal sex. Apart from the fetal anatomy, some other features should be assessed as well. First of them is the placenta. Firstly, we should assess placental location in relation with the internal cervical os. And secondly, the appearance should be described. We should describe the structure, and if there are any hematomas or tumors, it should be noted on the scan report. We need to remember about morbidly adherent placenta spectrum, as the rate of cesarean section deliveries is getting higher. High-resolution probe with microflow imaging should be very useful in such conditions. Very important is also cord insertion of the umbilical cord to the placenta, as velamentous cord insertion can be associated with vasa previa. So in summary, I would like to give some take-home messages. A systematic approach is essential to ensure that anomalies are equally likely to be detected for patients of any risk background. Therefore, we should follow recommendations. The first trimester ultrasound has developed into an opportunity to screen for a number of significant fetal anomalies. So, with increasing resolution of ultrasound imaging anomaly scan now moves to 11 to 13 weeks. Detection rate for certain lethal fetal anomalies can be as high as 100%. Therefore, the crucial thing is to know as much as possible as early as possible. Thank you very much for your attention.